Psychiatry with Nottinghamshire NHS Trust, and a Professor of Psychiatry and Community Mental Health at the University of Nottingham. But I actually found him through an organisation called MindTech. It's a multidisciplinary organisation looking at kind of technology within mental health, but he's going to tell you a bit more about that and a bit more about technology and sort of stuff like that within mental health.
Well, thank you for inviting me. I'm always a big fan of meetings organised by trainees for themselves rather than being forced and corralled into something that they don't want to hear. So thanks for inviting me. So that's a picture of one of the things I quite like about this topic and the building that I work in, which is that building, is it rather suits it in terms of it's all quite modern and in terms of the campus. But digital health, why now? Why should we take notice of this? Well, it's a 30 billion, and I've just been told the other day that it's now only 22 billion. These are eye-watering amounts of money. There's an NHS funding gap of somewhere between 20 and 30 billion which needs to be closed, and it requires us to do things differently. There was a report that went to commissioned by the government, which was reported back in April that said that 25% of people only with depression, anxiety and mood disorder receive first-line treatment. That's the first-line treatment, not the treatment they should get, but the first-line treatment. So there's a huge gap between what is required and what can actually be delivered. And then in any case, people want to be treated differently. People want more flexible care, they want more person-centered care, they want to help themselves. Well, I carried out research in various parts of the country in primary care waiting rooms. The usual first reaction of most people is, I'd rather manage it myself if I can, rather than I want to be seen by a health professional. Advances in computer science and bioengineering, I would argue, are ready now for this sort of thing. There's a rapid growth in smart technologies, but we do have a problem in that the agenda is set by people who can design these things. So we're largely getting what engineers and computer scientists think we want or develop. An example of this was even in my own institution, we have a very good computer science department and engineering department. They came up with a two-way mirror and then asked me, what do you think we could use it for? But that's the way things are. It's the wrong way around. So Britain's ready, I think. And that's a slide which is a few years old now. But at the bottom is the rather disgusting thought that more people own a mobile phone than a toothbrush. That's based on a number of self-reports of how many people have. A lot of people access the internet. People say they will use it. Whether they really will use it for something like mental health, I don't know. If we have time, I will try and get into this. I will talk to you a bit about what I think is a growing problem, which is digital exclusion. But there are key challenges. I mean, there are already over 70,000 apps for mental health, if you take a fairly broad view of mental health. There is a need for earlier user involvement and needs-led design briefs. We need robust business models. How do you make money out of it? So typically, someone develops it because they can. It's around for a short period of time as an app, and then it's withdrawn. Sometimes replaced by something better. A bit like, there's always a new version of Windows, always a new version of this, or always a new version of that. But it does make it problematic for people if they can't get a reliable product. Then identifying and translating research innovations in computer science and engineering to benefit mental health care is a problem because these are not natural conduits. We don't naturally talk to those types of people, or haven't done in the past. So they have to be creative. MindTech's an example of one of those things, which is it's an organisation centred with engineers and computer scientists working across with a range of mental health professionals and other types of academic And then there's very limited evidence of the clinical effectiveness. In fact, Public Health England produced this rather alarming graph, claiming there was an inverse relationship between the population for health app and the evidence of effectiveness. And then we've got to think about this a bit more carefully. You know, I'm trying, in the process of publishing or trying to publish some randomized controlled trials I'm quite proud of, and it took a long time to do. But they weren't on technologies. They're just on, one's on a service and one's on a psychological intervention. And they're delivered in old-fashioned ways. They were developed in the way we normally did them. So we did a bit of feasibility work, then a pilot work, and then a definitive trial. It takes 5 years to do a randomized controlled trial. It takes about 20 years to do something from scratch to fully through to a full trial. Now, there's no point even starting that with any piece of technology. What bit of technology is going to be the same in 20 years' time or even 5 years' time? So we have a real problem that the current slow way in which we do RCTs is just not suitable for the topic area. I'm not saying I've got solutions to all of this, by the way. And how do you regulate and quality control an app? An app's a program, it's easy to do. Not easy for me to do, but there are plenty of people, probably people in this room who do it. So how do you regulate it? How do you quality control it? Why do you need to? Because there's a potential for harm. There's vulnerable people out there, and things are being developed for them on their behalf. They could also be used to exploit people. And then what about scalability and implementation? How do you get, if supposing there was something really good, how do we go about publicising that? There are obvious ways of doing this through crowdsourcing for people that are already familiar with these things. But how do you reach people who are not familiar with these things and don't use them normally? Then there are issues of privacy, trust, consent, and data security. If you ask people what their main concerns about these things are, they're often around data protection, data security, lack of privacy, who else can eavesdrop, that kind of thing. A huge practical problem is their interoperability, and in particular, the problem of using things within NHS workplaces. We've got all sorts of things that we can use at my university base, or even from people's homes. You try working them in an NHS clinic, and you'll find that the firewalls and the lack of bandwidth and all sorts of problems like that prevent you from doing it. I've had instances where I can track people. I'm supposed to work in a community mental health team. I have nurses who are supposed to, and other types of people who are supposed to be in closer contact with health professionals, but sometimes it's better for me to monitor them and in terms of their digital activity, because I can from the university, and they can't access blogs, websites which tell them that they're going to commit suicide or whatever. So that's a problem. Then there's a problem of digital exclusion, multiple disadvantage. So mental health strikes some of the people who are very poor, educationally, did not have a good start in life, unwell currently, can't concentrate, can't plan, they're chaotic by nature, they may have substance use problems, they may have had a history of abuse. I've been trying to do a project with people who self-harm, but one of the problems is that they have to change their phone number all the time because they're being pursued by people. And, so unfortunately, those things are not sort of separate groups of people. There's a group of people who have all those problems. How are you going to get them involved in this? It turns out that while, unfortunately, the poorest part of the community has to get used to using the internet to make claims for benefits and things. And they'll do that with a bit of help. But that does not mean that they're willing to put intimate personal details and about their mental health. They make it very clear. Most people will say that they're happy to engage in this kind of mental health technology, but only if they own the means of which to, their phone or own their contract and own or own an iPad or something like that. They won't borrow somebody else's. And they won't certainly go to a library. That's the problem. They might go to a GP surgery if they can be convinced that they're not going to be overlooked and they're not going to be, other people can't overhear them. So digital exclusion. So one of the reasons I suppose Mindtech might be at Nottingham is because we have the Horizon Centre, and that's something that's funded by multiple research councils and Wellcome Trust and all sorts of places. And it's a place where there's a lot of computer science and sociology. So Nottingham as a city is better profiled in terms of its activity using internet and digitally. One comparison was a well-off part of Nottingham, Wallerton, and the poorest part, Astley. 25% of people don't own any form of internet, and 75% of them, another way of looking at it, this is a good way of reaching poorer people, because 75% of people are connected to the internet and do have the means of and can use it. But even in the well-off part, 95% did. Interestingly, some of the 5% that didn't want to. That was the main reason they didn't. And that's always got to be considered. And another thing that one also has to consider on all this is that, interestingly, we asked the question, well, who is it that most wants to be connected but is not connected? And it turns out it's all the people who are isolated. Some of whom are isolated by physical illness, some by mental illness, some by social reasons, often a combination of these things. Quite a lot of them are older and have no immediate knowledge about how to do this. And since library services have been curtailed rather severely, then it's quite difficult for them to get any kind of training or help. Some of them saw the possibility of using these things as being literally transforming the quality of their life, because they'll be able to interact with people. They can't do that. They're very limited contact with people who come to the house and not much more. So we don't understand the full potential of all of this. We don't understand the optimal way of utilising most of the new technology. But hopefully, I know I've put a lot of challenges. Within challenges are opportunities. And what I really like about it is I think NHS mental health care can, at its worst, be a terrible monopoly provider of expertise. You know, I'm sick of hearing people, I'm the expert, you do what I say, kind of thing, no choice. You get what you're given and be grateful for it. I don't know if that's an attitude you've come across, but I can assure you it's out there. Now, what I do like is the engineering and computing aim to empower the consumer. So this sometimes causes some quite interesting conversations, because computing and engineering, computing scientists and engineers just don't see why the NHS should or would behave this way. But their view is that what they're there is to empower a consumer, whoever that is, to do what they want, when they want it, and preferably at cheaper cost and faster than they can do it now. Now, that isn't how the NHS works. So I think that like other, what's called technically a disruptive technology, power can shift more towards the consumer. But that can only happen provided it really does what it says it does. Otherwise it might be an illusion or be ineffective or be harmful. So, I would say, now this comes to where Mindtech and people like me become involved. Engineers and computer scientists don't usually understand any of those kind of things, but also don't understand clinical practice and clinical work. So people like me have become involved in this. I'm more interested in how you use this stuff and what you can do it with. I'm not so interested in the technology itself, if I'm really honest. But we desperately need people like yourselves that become interested in this. Otherwise, we'll never will realise the full potential. So, I think we have to accept that digital technology is a tool, Your last speaker was quite sociological in perspective, and I like to think I am as well. So basically it's still a communication instrument, and it's still based on the quality of that relationship. So social relationships are incredibly important. But it opens up a whole new range of different social relationships. We've just recently done a trial in bipolar disorder, which is one of the main things I look at, of an internet site offering psychoeducation. It wasn't that innovative because there have been 2 other previous studies. But what we've managed to do was get a much better retention rate, and people utilised it over a 12-month period. And when it came down to it, the reason for that was that they liked our team, the people that initially spoke to them, and they saw the technology as an extension of speaking to that team. They didn't like some of the other people because they felt they were distant, disinterested. So the technology wasn't hugely different, and the content wasn't hugely different. It isn't wonderful, and nor was what you could do with it incredibly different. What was different was that the extent of the way that they viewed the technology in the context of a relationship. And I think it's very important to remember that. I think there are also unrealistic expectations. So, digital technology can't solve all mental health problems. It's not going to solve that funding gap in itself, and it's not going to. It can make a contribution, but it's better to think of it as a tool, and it's a powerful tool, though. I don't have any expertise in the technology itself. It's not necessary to be. I think it could enhance what you do with this if you do have a knowledge in it. My expertise is in clinical practice and applied research. So just very quickly, Mindtext, and then I was going to show you some of the things that I'm involved with. There are 8 of these, and what they are there to work with companies in the main, sometimes other universities. They're not supposed to just push things that Nottingham are interested in, nor are these others. They're funded by NHR. They're funded as a centre, so 4 to 5 years at a time. And they are still a bit of an experiment, one has to say. And they're really trying to expand research and assist take up of these things into practice once they're properly evaluated. So that's where we work. It's all quite sort of futuristic with these what I call Lego buildings in red. And my university likes developing building buildings that are sort of unusual. But the important thing, if I had a pointer, I'd be able to show you that computer science is not very far away, engineering is not very far away, the business school is not very far away, and we have our own in-building institute. My clinic is a bit off there, but it's 15 minutes walk away. So there's a lot of co-location, and meeting people and talking to people is very important with all this sort of stuff, because you have to develop a shared understanding. So the basic idea is to create a pipeline. So that's sort of schematically what you do. It's based on an idea. I was also very involved. I was being a Clark director and a director of research in the current Clark. And what are Clarks? I don't know if you know what they are. University College London has one. They're centres for applied research, but very much into practice, into this. And the conclusion there was a way, they're now in their second phase. The conclusion of an independent evaluation first phase is that when it comes to implementing things from research into practice, then the main reason they're not implemented is in fact because the intervention was never designed for the right purpose. Absolutely fundamental. Amazing how much money was spent to find that out. So people do traditionally develop something with great rigour, great care, but it's no use. It just does not reflect the problem it was developed for. So this has been done. So what we're trying to do, you've got to start from the design initially, And then implementation, even if you do design it correctly, there are still a lot of other challenges. But it's quite a deliberate process. It's not something that's just left to chance. So the research approach is identify what the clinical problem or unmet need is, develops or identify technological solution that works with, often in the context of some service or some other approach, evaluate clinical cost effectiveness, adopt it and try and disseminate it. The words around adoption, dissemination, there's a lot of debate about what the right words are. Disseminate sounds too passive. Implementation, nobody knows what that word really means. That to define it and agree it locally, we say it's putting it into practice. But there's a whole load of implementation science, which is quite challenging to read if you're not familiar with it. But that's the alternative. Basically, you're just quite haphazard whether things come into practice, and so that's what we're trying to move away from. So current digital approaches, well, I can only give you a flavour of it. When I put this together, I realised it doesn't even reflect all the work in my own theme. And one of the things that was missing, that I sort of thought, well, do you need to hear about it? Hopefully you know about it anyway, because it's centred and based here. Is the virtual reality stuff with which Chris Bruin leads. And I did ask whether he'd come to talk to you about it. I haven't included it, but I will mention it very briefly. Perhaps I'll mention it as we come to something nearer to it. But these are basic things. So the first thing, the technology is already here. It's not an option from my point of view. I had a rather dispiriting experience just a few months ago, hearing a group of child psychiatrists and child psychologists who thought it was an option not to talk to people, including the children, their patients and their families, about technology. They didn't like the idea. It's a bit, you don't want to dirty your hands with it. And it seems ridiculous. Some people I talk to spend 14 hours a day on the technology. So you're not interested in their life then. That's what basically you're saying. And then, so what about all the issues like people being bullied on it or being isolated? There's lots of stuff on there. Technology is here. It's not a case of, that bus is long gone past. Technology it's here already, people use it. I have a group of patients who come in, the first thing they do is they come in through the door and show me their phone. And they show me their phone with a PHQ-9 app with a nice graph. That saves me 10 minutes of asking them the standard thing I ask, how have you been since I last saw you? So they can tell me. I know that is more reliable than what they would have told me, because they did it at the time. And I'm asking them to think, well, 6 weeks ago, what did you do? 6 weeks ago, what did you do? How many of you can tell me straight away? So they score it. Not everybody does it. Only a small number really do it. And the number of people that sustain that over a long period of time is even smaller. But it is quite useful to do now and then. Another thing that we do, I particularly like doing this. I've got a couple of studies in doing this, and a few people are starting to try and use it in real life practice. Remote video therapy, it's not very technological. It's only the same thing that you would use for education, has been used for a long time for distance learning. It's web-based approach, but it has lots of advantages. It reaches more people. It's massively cheaper than other things. So we use Cisco, which makes something called WebEx, which is a classic thing for remote education. But for £27 a month, they will supply it and they will maintain it, and we pay that per therapist, however many people they see. So now if you compare that to telephone, then they would be paying per minute, and we don't have to pay any travel costs, nobody goes anywhere, and it's hugely more flexible. I see a lot of students, so do some of the people I work with. We've been talking to somebody who's just gone to France. That's not a great deal. The thing that I like to talk about is the one time that and it was only once, when we actually talked to somebody from the Trans-Siberian Railway, so we're going across Russia. But distance is no limit. We often, more mundanely, we are running studies without having to see them at all in terms of consenting them or delivering the therapy, based in Nottingham, going up to Yorkshire, Bradford, Stoke, and the more rural parts. It means that you can also give very specialised therapy to people in places that could not possibly have access. I noticed that we're not very far from the Tavistock, and you heard Tavi being mentioned. Well, most of this country does not have a Tavistock on its doorstep, and so we cover. But someone from the Tavistock could literally, if they use this technology, reach anybody that had access to it. So that's what you can do, and that's a hugely powerful thing. Of course, some people don't like it, and they don't want to do it. There are a number of things that you have to think about. There's a lot of people's technology machines. What we found is that there is an extra cost. We need to send them a set of headphones and a microphone. But now that we do this at such a scale, that's £7 a time. That's because most of the equipment is poor in that respect, and we need a good connection. It's easy to use. We send them an email, they click on the email, that's all they have to do, put the headphones on, so make sure the machine's switched off. From the therapist's perspective, it looks like a standard electronic list of patients to see, and again, you just click on it, it opens up. There are things you can do. You can record things much more easily than you can in real life. A lot of people, particularly anxious people, like the recording. It's already, they replay it over and over again. So I don't know for sure, but there might be direct maintenance effects. So there are problems. I mean, reliability. When you're dealing with people who are in abusive relationships, you have to think about who could overhear this. Who else is in the room? If you've never met them before, exactly who is it that you're speaking to? But people prefer video rather than voice. This is something else that is routine and around everywhere, mood gym. There's lots of evaluations of it. It's an online CBT program, best known of them. There are a number of them. Anyone can use this any time. It's fun to play around with it if you haven't. A lot of people I see have used this already before they've come to see me. We're doing a trial of something called Big White Wall. You've heard of that? That's an online peer support group, people helping people. The best way of looking about it, I think, is it's a safe Facebook, but a moderated Facebook. There are people there. What's great is there's no waiting list whatsoever. You can go at any time, and in fact, people often are on it at all sorts of unusual hours. It's moderated through the night. At the bottom there is the person who set it up. I don't think she's now the CEO, but she was someone who suffered from depression and doesn't mind saying so. She happens to run a hedge fund, which is quite useful. So, and this illustrated a kind of entrepreneurial spirit that some of this is being done. And this is our trial of it. We're trying to recruit 2,000 people across Nottinghamshire to evaluate it versus just giving information. So essentially what digitally provided peer support will provide, and looking at clinical and cost effectiveness, some of the things we do. Another Nottingham thing is trying to measure depression more objectively. You can do this by sound, you can do this by vision. The standard mental state examination would be to observe how someone speaks, how somebody looks. Now, computers can do that more accurately. You know, they can measure speech to very precisely. So whether this is more useful, I found it useful in persuading people and motivating people to take treatment. Sometimes people with depression don't really believe you, or they believe that you're trying. When you say that they look better, they say, well, Yeah, you would do, wouldn't you? But if a machine says that you really look better, and they are better, they tend to believe it. So I've sometimes found that useful, particularly with depression. So you can look at other types of emotion. More imaginative things and things that we're moving towards. Use of artificial intelligence, and you probably may have heard about the Internet of Things. Soon your milk carton will have sensors in it, and everything will have a sensor in it, whether you like it or not, whether you even know about it or not. This does raise the chance of using things quite constructively, for instance, through a mobile phone. So my particular thing that I'm interested in is looking at early warning signs of bipolar disorder. They're very personal, and we need something that would use particular sensors to detect particular things. And you can integrate it. Another simple approach, the big leading place for this is Northwestern University in Chicago with David Moore. Just simply using positional data and trying to work out what somebody's mood is. If you know what people like to do and you can contextualize their activity, you can see how people are. And we've done some of this in Nottingham. So this is that's actually a map of the university and where someone lives, and that's their journey. They work and they go from one place to another, and that's what they were like when they were well, and that's what they did when they weren't very well, when they were depressed. And you can see quite a dramatic difference, can't you? Now, I'd be careful about interpreting things like that without knowing quite a lot about them. You'll find the different patterns between weekdays and weekends and so on. So you do have to know quite a lot to be able to use this, but it is quite an objective measure and it's simple to use. And if people don't mind and don't find it too intrusive, then you could use it. Now, the matter of data intrusion, when I first became involved in this, there were all sorts of things that these engineers said they could do. And they're saying there's no way people are going to allow them to do that. Monitor bank accounts, monitor where they are. But when you speak to people, and this is where it's so important that you do get a user design, they're much more practical than that, and most of them are. They say, well, it all depends on how bad things are and how much things are. It's about their choice. So we don't have to impose, there's no pressure of imposing this on anybody. We're not tagging people. We're saying, if you wish, we could do this. So this is getting more closer to virtual reality. Virtual reality can be used as I think it's potentially quite terrifying actually what Chris Bruin's doing. But he's basically using it in the context of psychotherapy. We have our own version of this, which is a bit more benign. So our version of it, which is produced by a company called ProReal, is basically a kind of art therapy, where helping people in a psychotherapy context to talk and to demonstrate things which they find it very difficult to articulate visually. By words. So they'll take something which is a representation of a person, and they can do like avatars. These are basically avatars. You can give it the voice that you want, you can make it the sex you want, you can alter the size. You can put them in different scenes, so you can recreate something that looks at least schematically a bit like how things were in a particular context, and you can do all sorts of things with it to help articulate it. You have to make sure that it is a tool for psychotherapy and doesn't become a game that dominates the therapy. Because it is quite fun to do to a degree, and you can just get carried away with essentially playing a game rather than doing the psychotherapy. Now, Chris Bruin's version is that you come inside basically a suit, and you create someone who was your mother or your father or stepfather, potentially someone who's abused you, and you say what you want to say to them, and you act in the way you want to act to them. But it seems to me that you've got to be very careful and skilled with using something like that, because it's just a little bit too vivid at times. But potentially could make a very large breakthrough. It's quite an intensive approach. It needs a lot of skill to use it properly. But nonetheless, that's a virtual reality. Now, what we're trying to do, and my particular thing is that unfortunately, the term saint is not my term. I don't like it because I hate anything with a religious connotation. It's just me. We've actually decided to call it Melinda. Having asked people what they would prefer a female rather than a male, though you can call it whatever you like. The saint is actually a name of a type of approach, which is sensitive artificial intelligent narrative therapist. The aim of it is to develop something which can maintain psychological treatment. I've always been concerned about the fact that people seem to think that a lifelong condition such as depression, bipolar disorder, anxiety disorder can be fixed in 6 to 8 weeks of the treatment. It seems inherently unlikely to me, and that or that you have your 6 to 8 weeks, or even 6 months to a year. It changes the trajectory of your life, and off you sail. Everything's fine. I just think that's just not lifelike, and it doesn't. You know, maybe I know maybe don't see the people that doesn't suit, but to me this offers an option. Maybe we could do something to maintain things. Maybe we could do something on a slower scale. So what this is it detects your mood. So this has been based on depression. So it tries to assess your mood from the way you speak, it's the therapist programs it. Not literally, because that's all done in the computer sciences, but to provide a certain level of response according to the mood. And it's designed for people whose mood fluctuates, so they will give different responses. After a while, you change that. You do this completely collaboratively, and only with the person wishes to. It's not forcing people to do anything. So we can do this. We're at an early stage of finding out whether this is worth doing. But theoretically, you could see people as a therapist or a psychiatrist or mental health professional, and then see them at certain time intervals and change that over a process of time. Where this has worked very well is actually in conditions like social phobia. I'm not the right person to talk to you about that, but social phobia, it's very hard to actually treat in just with traditional means. But you can create situations that people are already afraid of, and then expose them to it with feedback. And again, you can use the avatar to look at look at eye contact and avoidance. Other people have used this, of course, with hallucinations. So I understand you've heard something about Daniel Freeman's work. It's a similar sort of thing. You can use this for psychosis. We don't do so much. We don't really do psychosis work. So our concentration is on depression. So cranial stimulation, again, that's been around for a while, but we don't know how to use it best. But we're doing a couple of things around that. These are magnets. One of the advantages of this is that very few side effects, except that because they're quite weak, you have to use them often, and that's a limitation. But you can also use them with CBT. So various places are using this alongside other treatments. So I'm conscious that I've been speaking for quite a while. When should you need me to stop?
Soon-ish.
Yeah. Okay. Okay, something that we've got a big European trial of is, which is with Oxford, is something developed by a company called Pivotal, and it's a computerized emotional test battery. What this tells you is whether whatever treatment you're using for depression, is it likely to work? What's been worked out has been what is the order of things that improve. I don't know if this is something that you've all covered, but something that perhaps we should start to be talking about. So it's a battery of 5 tests, and you can send it over the internet. If it can be done as quickly as 15 minutes, but usually people with depression, because they tend to like to be quite precise about things, will take longer than that. We're trying it at home. The first studies were done in GP surgeries. And you're just asking the person, what emotion is that is shown on that face? The first thing to improve is your observation about emotion in other people. Nothing to do with yourself. And it's on the basis of negative emotional bias. So a person with depression sees everybody with more negative emotion than other people do. If they are responding to treatment, in this case an antidepressant, after the first session of treatment, you could work out whether somebody was improving or not. It doesn't tell you, it only tells you whether somebody will improve. It doesn't tell you what needs to be done. It just tells you, are you on the right lines or not? QBTech is something for ADHD. We've done a big trial of it. It's not depression. This isn't my work when I'm a bit more peripherally involved, but I helped design this. But ADHD is incredibly vague kind of thing. And this can measure your attention, your hyperactivity, and gives you feedback. We've shown that people diagnose and get stabilised more quickly if you use this than if you don't. And then this is something that we're not really involved in researching, but I put it up there because anybody can use it. And it's a real nice alternative to giving people hypnotic drugs for people with sleep problems. CBT for sleep in my part of the world is almost impossible to get as a service. I also like the fact that the people can actually access this when they really need it, which is when they're falling asleep, because they've got it at home on their phone. And importantly, because phone activity normally can keep you awake because of the ultraviolet light that's released from things like phones, they've got to, in the application they've dulled it so it doesn't do that. So, and that's available now, which is why I showed it. Some of this is not just in the future, that's available now. The only drawback is that some parts of the country, some commission groups, my city, Nottingham City, has purchased this for the whole population. So if you come to see me from Nottingham City CCG, I work across a couple of CCGs, then those people can have this. If you're a poorer person, you work from another CCG, and you can't afford the cost, which is for a course this is about £50 to £60, I forget exactly. If you can't afford that, there are plenty of people who can't. Then they can't access it, you can't get it, but unless they're willing to pay that subscription. So that's an issue. But the NHS has come to that. So the NHS plans to create an evidence-based list of applications, which is going to be on something called, which is provisionally, well, it's now called at the moment NHS Mood Zone. Whether a better term could be used, I think it will have to change, because at the moment most of the stuff on there is to do with depression and anxiety. But there are obviously other things like sleep, which are much broader than that, so it would be better if it was called something else. So in summary, I was making a plea to understand the pros and cons. It's here to stay. I don't think you can ignore it. Even people in my age can't really ignore it. They're tools to help the clinical role. If you allow it, it can help you. They don't replace you. They just, how many people use it in their NHS practice, and 2 people maybe, you know, and so you're comfortable using these things to a degree because you use them all the time. So so now what about using it in this role? And like, as I say, even 75% of poorer people, if you live in a deprived area, will be using these things. Over time, the clinical role will have to change as we understand how to use them. There is a point that a lot of this we don't know how to use properly, or we use absolutely well. But on the other hand, if we don't practice and don't use it, we will never find out how to use these things properly. And our role, I'm saying collectively, because I consider myself similar to you, is to facilitate, enable recovery collaboratively, often from distance. So I'm particularly a fan of getting people to devise their own management. I'm always quite happy. I quite like the fact that people come and argue with me and don't just passively accept it, because on the whole they'll do better than people who just follow my advice. It's not completely true. Some people argue we completely don't do well either. And I think we have to deal with the problem that 75% of people with depression and anxiety don't get any help. That is a huge problem. It's not acceptable. I don't know how many of those people want help. That's not what people asked. There's been a good proportion of people who don't want any help, but I would guess that if the figure is only 25% receiving the first line help, it could do with being improved more. How are we going to do that? Someone told me, it's not my idea, but someone told me to recruit enough IAP therapists to meet IAP's demand. They would have to take all 6 form leavers in the country for a year. You know, this infinite demand that's being generated cannot possibly be met. We've got to find, and we're not even going to be able to do it by the traditional NHS way of importing people from other countries. You know, we've got to find other ways of doing it. And I was just finally wanted to say to join us to help research this. It's definitely a growth area. We exist as a national resource, and we like to think sometimes international resource. We're not just there to help Nottingham. So thank you for that.
Thank you so much, Richard, and thank you for coming all the way from Nottingham as well to speak to us. So probably only have time for one question. Does anyone have anything they particularly want to ask? Sarah?
I was speaking just the other day with someone who's having their therapy online, so face to face, but online, I guess. I'm not quite sure how to say that, so not over the telephone. And she was saying to me quite clearly that one of the reasons she felt that it worked is that she had already met the person face to face and established a relationship. And I was just wondering whether you've done any work on the difference with people who do have that, whether they meet someone face to face first, or people who just do it virtually, and whether there was any difference.
Well, not systematically in the way that you want to. Quite a lot of this research, I'm used to doing research on complex interventions, so normal practice for me would be to do qualitative research as we go along and as to develop it. So in the context of that, we hear this sort of thing, sort of comparisons. But I have to say that I think there's a considerable amount of variation and choice, and I think this is one of the things that we could really utilise positively with these things. So there are quite a lot of programs. I've forgotten the name of one of them just off the top of my head, which are basically, but Big White Wall is one example of this. You know, you never meet them face to face, you never see them, you wouldn't even know what they look like. Everything is done in a written form. And for some people that is ideal. You know, it's better to talk to a stranger, and it's better to talk to without having to look at them. I mean, there are problems with that. You know, how do you know you're talking to who you think you're talking to? But for other people, I have to say, for instance, in our health anxiety trial that we're doing, we have an option of using telephone or the WebEx kind of thing. The vast majority of people prefer the video link and video material, and some of them start off with telephone because they're nervous and they've never used anything like this in their life. But and our therapists are quite adept at moving them on to that. But so I think that the beauty of these things is that there's quite a lot of options, and I would hope that we could retain that, because people require and want different things. But, so I don't think there's one's better than another, really.
Thank you again. So we'll just have a quick sort of 5-minute break now to try and keep us running to schedule, and then we'll talk a bit about drugs.